Okay, so we had one of the previous lectures was narrow complex tachycardia, so kind of like a natural progression now to wide complex tachycardia. So just, before we start, like, you have to know this is a very, very tough topic. So you will, if you, I don't know who was coming to our EP conferences, but if you throw an EKG with wide complex tachycardia into a room full of EP doctors, they will get into a fight, whether what type of tachycardia that is. So it's very hard to just, sit down a couple of hours and read over this and be completely comfortable of diagnosing everything. So really, my goal is going to be to give you some, concepts of how to think about the wide complex in general, and again, to develop a differential diagnosis. Once you have that, you kind of narrow down, all the possibilities, and then you can, it becomes more operational in the clinical sense, and you're not going to get confused what to do next. So all right, so the outline, so what we have to go over is, so first we have to understand, how the QRS complex is generated, and because you have to know normal depolarization and why the QRS complex looks the way it looks, and then you will understand, some variations of abnormal depolarization and why it becomes wide. Once we go over that, then we're going to go to differential diagnosis, and then we'll have some examples. So first of all, normal depolarization. So let's talk about that. So this is important, and just try to pay attention to this. And essentially, what you have to remember is this. So remember when you start reading an EKG book, by convention, when you have a lead, the positive deflection means that the wavefront of depolarization is going towards positive electrode of that lead, and the negative means the wavefront is going away from positive electrode of that lead. So in this example here, you have a lead 2, right? And you have this is your negative and positive, electrode, and this is how normal depolarization wavefront goes. So first, your mean vector of activity goes from left to right and depolarizes the septum. That's your first picture. And if you take lead 2, this will be variable depending on which lead you're looking at. So we're taking this as an example. That's why you have your first negative deflection as your Q wave, right? Because this mean vector goes away from this positive electrode here. So then the next, as the septum depolarizes, the next thing what's happening now, the depolarization goes down and goes straight towards the positive. So you have a big R wave. Then it further continues more towards the left because you have more of the left ventricular mass is larger. So you will have the a little bit of delay there on depolarization because there's so much muscle to depolarize. And since now you see how the arrow is kind of slowly going away from this positive portion of this lead, and that's why your still R wave is present, but the deflection is going down. And then finally, the last to depolarize is the basal lateral areas. And in that last moments, actually the mean electrical vector goes away, and then you have your S. So this is how normal QRS occurs. And now knowing that, I'm going to literally do this exact same thing, just looking at leads AVF and 1. So once that initial negative, you have septal depolarization, and you just follow what's happening in AVF and 1, and then you have towards the lead 2. Next moment goes more towards the left side, and finally depolarizes the basal lateral wall, and you have full depolarization. This is very important to understand because then you get a full understanding of bundle branch block morphologies and other ventricular arrhythmia morphologies, because without this, it's really going to be just a guessing game based on the width of the QRS complex. So this is to illustrate the same concept, just when looking at the precordial leads, right? So you see your V1 is here, the lead, and V5 is here. So if you focus only on this QRS portion here, so you remember initial left to right, your V1 lead is going to have a little positive deflection here. Then goes away, your V1 is going to be negative, and then the opposite happens in your V5, right? Sorry, guys, just one thing. Okay. So essentially, it's the same principle, because the signal is going towards or away from the lead. So that's your normal, right? So before we go to this, I need just someone to tell me, when you see a wide complex on an EKG, regardless of that's tachycardia or slow rhythm, you see a wide complex, what is your what are the possibilities? And it's very limited possibilities. And just whoever, I just want to get a feel of your thinking about this. Whoever wants to say, and whatever you know, that doesn't matter if you don't know anything, just at least one differential.
Bundle branch block.
Okay, and then anything else?
Ventricular.
W.
Okay, and then you have ventricular, right? And anything else?
Afib was variable block.
Okay, so you're all on the excellent, you know what you're like, that's a good way of thinking. So I'm gonna summarize that now, right? So all these things that you were talking, and very limited possibilities. So whenever you see a wide QRS, can be bundle branch block, with keeping in mind that bundle branch block can be something because the patient has, existing structural abnormality of conduction system. They have bundle branch block at any point in time. And you can have a functional bundle branch block, which happens in certain situations when you probably heard, rate related bundle branch blocks, that can be transient. So that must not fool you, because some people at some point, depending on the behavior of their heart rate, they can have bundle branch block, and then it just it disappears. Then obviously ventricular rhythm, whether that's a slow escape rhythm, whether that's a idioventricular rhythm, or ventricular ectopy. I'm sorry, guys. Do you mind? I just need to pick up one call. Give me.
Of course, take your time. Hopefully not a STEMI neuro.
All right, sorry guys for that. All right, so yeah, essentially, any ventricular rhythm, and then as someone said, WPW, meaning any pre-excitation, and then paced rhythm. So if you know these four, this is your essential starting point for everything. And one thing that is often overlooked is the effect of electrolytes, electro abnormalities, drug toxicity, or antiarrhythmics. So if patient has some of these, that can give you a very like bizarre, why complex rhythms that you're kind of confused, you're not sure what it is, but that can, definitely has to be in your differential diagnosis. And then, in your right bundle branch block, as you know, now that you know normal depolarization, in the abnormal depolarization of your right bundle branch block, essentially what happens, you just have a very delayed activation of the right ventricle, and that's really the consequence of the morphology that the consequence why you see the morphology in V1 with your RSR prime, right? Because the R prime is really that delayed right ventricular depolarization that you see. And that's going to be important because in ventricular tachycardias, you'll have a little bit of different situation. We'll go over that. And left bundle branch block, same concept, right? You have a very delayed activation of the left ventricle, and then what happens? Your V1 then predominantly is really like negative, because the vector goes away from lead V1, and V6 and V5 are going to be monophasic. And as you might notice here, that little septal depolarization from left to right is lost in your left bundle branch block, because that branch is coming from the left bundle. So that's why you essentially lose your little Q wave in V5 or your little R wave in V1, because you've just lost that first step of left to right septal depolarization. So those are your bundle branches. Then functional, bundle branch block. I was thinking to go over this in detail with you, but I think it's probably going to be too much. But let's just remember one concept. That's when if the patient can have at certain heart rate, something we call rate-related functional bundle branch block, where at a certain threshold, let's say above 120, above 130. They develop bundle branch block, and then if they slow down, that resolves. So that's something that you should look always in telemetry and EKG to see if there's a window where the heart rate dropped, then you see if the bundle branch resolved or not. So there are other mechanisms of functional bundle branch block, just for you to be aware. But maybe we can go over that in detail some other time, because I want you guys to practice a little bit of other cases. So now, again, one possibility, bundle branch, the other ventricular rhythm. So, and as you know, like ventricular rhythm, you have a focus somewhere in the any portion of the ventricle, and you will have a genesis of a wide QRS. And if the semantics is really based on the heart rate, anything that's above 100 is going to be a VT, or anything that's less than 100 and above 50, it's going to be your idioventricular rhythm. And then ventricular escape rhythm is really those slow, wide rhythms of like 30, 40. So now a concept that I want to illustrate here is that, depending on where the ventricle, if you're dealing with a ventricular tachycardia, ventricular rhythm, that there will be a variability of QRS complexes, really depending on where the signal is coming from. So, if you have, VTs that are coming from the lateral wall, that means that the whole depolarization of the myocardium is very inefficient and slow, and those are going to be our widest type of QRS. And then if you have like something like a septal location of your focus of ventricular activity, you see how it's going to be much narrower. And then one of the ventricular tachycardias that can particularly be deceiving is fascicular ventricular tachycardia, because that arises from actual conduction system, from the Hisco-Purkinje system of the heart, So that's and essentially meaning if it starts from there, it actually utilizes a portion of your conduction system. So that's going to be your narrowest ventricular tachycardia, and it can be very deceiving in the sense that you might think it's a supraventricular rhythm. But again, this is not to be exhaustive of how to localize where is the PVC coming from, etc. Just to illustrate the concept that you know how to look just based on the width of the QRS, you can always immediately get a sense. You know, are you dealing with something that's more like the starting from the septum or more from the lateral wall? And then you have pre-excitation, right? If you have an accessory pathway, you will have a delta wave, meaning, and that will kind of produce a wide complex, meaning if your signal starts from the SA node, it gets blocked in the AV node, and then goes down the accessory pathway, and then you'll have a wide QRS. Someone will be in sinus rhythm, but your QRS will be wide. And then you have a situation in people who have accessory pathway that you have antidromic arrhythmia, where, so if you look at this second illustration, what happens, you have a PAC. PAC gets blocked in the AV node, goes down the accessory pathway, goes up here, AV node recovered, initiates a circuit, and then you actually have a wide complex tachycardia. Which is then one of your differentials, you know, for VT. So that's your third possibility of wide QRS. And then finally, you know, ventricular paced rhythm that you have to always take into account, because sometimes the pacing spikes are very hard to see. And if you're in a rush and you just see a very fast rhythm, you might neglect the presence of pacing spikes. So that can be also your possibility. So ventricular paced rhythm that will produce your wide QRS complex are essentially RV pacing. And it's the same concept as I told you for a PVC coming from, you know, a certain place in the heart. So this is essentially what happens, right? You have pacing from here, you generate a wide complex because it really behaves as a PVC. And then in your other situation, you have biventricular pacing, where you have two leads, right? One is the lead in the left side in the coronary sinus, and one is in the RV apex. Then you will have a little fusion of two signals, but they will also produce a wide QRS complex. All right, the his bundle and left bundle pacing, I just wanted you to know that that's a possibility, and you'll probably be seeing that a little more in the future as this gets more popularized. But those should not give you as wide QRS complex. So now let's go over the differential diagnosis of wide complex tachycardia and what it encompasses. So the first thing, again, it's a little bit of a hard differential diagnosis, because there can be many possibilities. So the way I think you can simplify thinking about it is, first you will answer yourself, am I seeing a regular rhythm or I'm seeing an irregular rhythm? Then you need to answer your question whether what you're seeing is a ventricular tachycardia, meaning it's coming, there's a abnormal circuit or abnormal activity in the ventricles, versus supraventricular tachycardia that is driving your basically your ventricular, your QRS complexes, and that's what you're seeing. And for that, there's a whole list of things that we have to go through that you have to also actively look in the EKG. So the reason why first question I wanted you to answer to yourself is that gives you this first kind of dichotomy of things. Because if you say this is irregular, and when we talk to narrow, it's usually when you have an irregular rhythm, whether it's narrow or wide, the possibilities are much more limited. So in this situation, if you have an irregular wide rhythm, you're either dealing with, VFib. You will know that patient is probably going to be coding. In the situation of polymorphic VT, it might be, hard to recognize, but usually patients who will be unstable. But sorry. Patients will be unstable, but in certain situations they could still remain conscious, and but once you identify polymorphic VT, you need to figure out why is that happening. And a nice way of breaking that down is if they had a normal QT in the prior EKGs, this would be your differential diagnosis. And if they had a prolonged QT, then you might be dealing with acquired medication-induced long QT syndrome or congenital. And the other possibilities that are rare is the atrial fibrillation in someone who has accessory pathway and WPW. And something that's actually very common is that someone has atrial fibrillation and they just had a pre-existing left bundle or a right bundle branch block, and now it just looks like a fast, wide, complex rhythm. When it gets tricky is when you have your regular rhythm, then the distinction between VT and SVT becomes hard, and we're going to go through the checklist of things that you have to go through. But in the case of monomorphic VT, algorithm is pretty simple for acute management, and that's really your ACLS principles. There's really not much to think about that. It's just later when the patient gets stabilized, you have to really go in detail and figure out, what is the trigger for that, what is the underlying condition, and how to long-term manage to prevent the recurrence of VT. But acutely, it's really simple based on hemodynamic stability. And then if you decide that you think the patient has SVT, then your possibilities are all of those same narrow complex tachycardia that we talked about last time. Because this is what you're seeing then is just that the QRS is wide, but the mechanism of arrhythmia is really like one of those narrow complex ones, like AVNRT, AVRT, etc. And then the other option is that you have AVRT that is antidramic. And as I told you, something that you shouldn't overlook is pacemaker rhythm, because pacemakers can cause sometimes tachycardias that appear wide. So this will be kind of a really good roadmap for you to kind of commit to your memory. And then once you encounter that clinical situation, you can easily narrow down your thinking process. So let's say now you decided that let's say you say patient has regular rhythm, and then now you have to figure out, am I dealing with SVT or VT? This is a very nice, simplified algorithm for you to go through sequentially through steps, and which some of them will favor the appearance of ventricular tachycardia. Some of them will favor the diagnosis of SVT. And you start really from here, right? For 0 says, does my patient have structural heart disease? Meaning, do they have a cardiomyopathy with scarring? Do they have ischemic heart disease? And I'm seeing a regular wide complex rhythm. The percentage of cases that are ventricular tachycardia is so high that you should really proceed treating that acutely with algorithm of VT. And you will not harm the patient that way, even if there was an SVT that you later find out. But you will harm more if you in that setting start delaying treatment and trying to figure out, should I give adenosine to figure out this AVNRT? So that should not be done. So now, apart from that, now if you later on when you stabilize the patient and then you analyze the EKG, it's very important is to get a 12-lead EKG. You can go through all these other criteria, and then that will help you figure out what is the diagnosis. So if you have precordial concordance, that's very easy. Then you will have it more favors VT. Then if you're and I will go through all of these in detail and explain you the underlying principle behind it. So then if your RS interval is more than 100 milliseconds in any of the precordial leads, favors VT. If you have AV dissociation, favors VT. And if you have something called morphological criteria, and I'm going to imagine there's little asterisks about this. If one of these morphological criteria is fit, then you probably have VT. Now that asterisks go down to this big table here, this is your morphological criteria. So if you have, and this is the whole point why I was telling you about that, how does normal QRS look like, and how does normal QRS look like in right bundle, and how does normal QRS look like in left bundle? Because the way to divide wide complex tachycardias that you're unsure what they are is based on how what is the appearance of the morphology in V1 and V6. So you can divide them into the ones that have more of a right bundleoid morphology, or the other ones that have more kind of like a left bundleoid, right? And then you go through how that QRS looks like and compare to a normally looking right bundle or a left bundle. So if you take right bundle, for example, and say, yeah, my normal right bundle should have a small R wave first, and then my S wave, and then a big R prime. The abnormal ones that are more frequently encountered in VT are the ones that have, this first deflection higher than the second one. So how you are going to see the saying, oh, the left rabbit ear is taller than the right one, but really it's just a reflection of abnormality of depolarization, because this is not right bundle. It's something weird that is depolarizing from the ventricle. You have a fully monophasic R, and that's really atypical for right bundle, because remember, we talked about all that septal depolarization, then goes down, then goes back up, and this QR morphology. So then R to S ratio in V6 should be less than 1, and that favors VT or QS complex. And the same applies for left bundle branch morphology, and then I'll show you in detail that morphological criteria later. So once you go through this and you say everything for this is no, then you can say, okay, maybe this was really supraventricular tachycardia. And then you go back to your narrow complex. I mean, colloquially speaking, narrow, because those are really the arrhythmias now that are left to analyze whether that's what's happening and the QRS is wide just because of functional bundle branch block or previous bundle branch block or something else. So all right, so first thing, right, precordial concordance, what did that mean? It means that across the precordial leads, all the QRSs have the exact same polarity. So if it's negative concordance, all the QRSs are negative, and if it's a positive concordance, all the QRSs are positive. With the positive concordance, what I want you to remember is that one differential diagnosis is very typical that is not VT, and that's your antidromic AVRT due to left lateral pathway. So that's kind of something that's easy to remember, that there's really only one thing that you should be aware of that could be a possibility, and keep it in your mind. But also keep in your mind that the antidromic AVRT is exceedingly rare. So don't think about any wide complex that this might be antidromic. It's really rare diagnosis, right? So assume VT first until you get more information. So now this concept, and I have mentioned a bunch of these like cutoffs, etc. But all these this milliseconds, that milliseconds, etc. All of those things are based on the following concept. If your myocardium in the ventricle has very abnormal depolarization that is ventricular in origin, the initial portion of that depolarization is going to be very slurred. On the other side, if you're dealing with the SVT and your initial depolarization is actually still going through a normal conduction system, then your initial portion of the QRS is going to be very, very narrow. And then later it's going to become slurred because you're going to encounter one of those obstacles like a left bundle or right bundle or some delay in conduction. So that's the fundamental difference between these purely like ventricular rhythms compared to SVT. And then a bunch of researchers and many groups have published their empiric experiences where they take, a lot of patients with wide complex tachycardia, and then they analyze, what characteristics were the most, predictive of the diagnosis of ventricular tachycardia confirmed later on EP testing. And then they came up with various cutoffs. And one of the easy ones is that if you see this R to S more than 100 milliseconds in any of the precordial leads, that suggests more VT. Now, AV dissociation concept, right? So AV dissociation is extremely helpful, very specific sign for VT. And you have to train your eye and always try to find that phenomena. And and this is one illustration where you see there when you can appreciate small little blips in the strip that map out, and they don't necessarily need to map out because sometimes you will see them, sometimes it will be hidden in the QRS, but whenever you see this little pattern where somewhere in that wide strip you have a breakthrough of these little blips that could be atrial activity, that's highly suggestive of AV dissociation. Really, the principle is the following on this little illustration is what happens, right? You have a very fast rhythm that's happening in the ventricle, and then occasionally sinus rhythm sinus rhythm is still depolarizing the atria. So it's just a matter of how fortuitous this atrial rhythm is. So it shows up on the part of the strip where there's no dominant QRS complex, and then you will be able to pick it up. So other phenomena that you might have heard is called fusion and capture beat. And these are really just these phenomena, if you find them, they just tell you that there's AV dissociation. So this is just an evidence of AV dissociation. But these are also very specific for ventricular tachycardia. So first, you have fusion beat. Fusion beat means, and as you can see on this illustration, where you have a part of your ventricle is depolarized from the sinus and kind of like, again, very luckily break through the part of the cardiac cycle where there was a part of ventricle that was able to be depolarized from the sinus rhythm. But then you still have the abnormal circuit that is not, quieted down. It's still happening and driving, other beats. So then capture beat is just kind of like an extreme spectrum of fusion beat, meaning that the timing was so lucky that you actually got to depolarize a significant amount of your ventricular myocardium through the sinus node and the AV node in a normal conduction system. But keep in mind, because the tachycardia is still continuing, probably there is still some tiny portion of the myocardium that is still depolarized by the abnormal circuitry in the ventricle, because otherwise the tachycardia would stop if you just fully depolarize the myocardium with normal conduction. But this is the concept of fusion and capture beat. Always try to find them. Of course, it's not it's rare to catch these. And now the morphological criteria. So let's go. If you see a wide complex tachycardia that has left bundle morphology, meaning that your V1 and V2 is going to be a predominantly negative QRS wide, and your V6 is going to be very positive. So if you see these things, so initial R wave of more than 30 to 40 milliseconds in duration, as illustrated here, and you have a little notch on this downslope. And if this entire distance from R to S is 60 to 70. Now, don't get confused with the R to S of 100 that I told you about a little bit earlier. That R to S of 100 was referring to any QRS in any precordial lead. This is particularly only if you have left bundle branch morphology and lead V1 and V2. So these things suggest VT. And then again, this is all based on the same concept, the same principle, that if there is really a ventricular rhythm, that you will have this initial depolarization very inefficient and slurred. And then if you go to V6, same situation, left bundle branch morphology. If you see the QS waves in V6, or you see a QR wave, that suggests more of VT. This is very hard to memorize, and there's really, it's really a matter of repetition. But again, it's just illustrated on the same concept that we talked about. In the right bundle branch situation, so if you have a right bundle branch morphology in lead V1, then you should look for the following. So if you have a very smooth monophasic R wave, as illustrated here, that suggests more of a VT. And here in this upper portion of this diagram, you can see nicely how like normal right bundle should look like. If you have a notched downslope to the R wave, like R and then small r prime, meaning this kind of pattern, or here, this in the middle. So this larger first, bunny ear is larger than the other one. That's more suggestive of VT. And then if you have QR complexes, it's more suggestive of VT. Again, this you have to incorporate all the clinical information. This is not an isolated thing. If I just saw one thing, yeah, I'm done. This is VT. And then in V6, same principle. If there are QS waves completely, that's suggestive of VT. And if you have this something called RS ratio that is less than 1, and you see the picture, how do you calculate this? So first R wave. Essentially, if R wave is really, really small compared to S, it's not normal to have that, because look at here in this little diagram, how a normal right bundle branch is going to look like in your lead V6. So those are the morphological criteria. The other thing that helps and suggests more toward VT when you're faced with, monomorphic wide complex tachycardia that you're not sure what it is, and that's your northwest axis. You will not be able to know this if you don't do 12-lead EKG. So don't miss the opportunity when you see something on the telemetry. Don't, perseverate on the telemetry and, and being worried of what is this wide complex. Just better get a 12-lead EKG that can give you all this information. So northwest axis is, just suggestive of VT. And then one also very actually pretty useful thing to look for and can easily be identified is one other algorithm, but particularly if in the AVR lead, you see a very dominant R wave without anything else, it's very highly suggestive of VT. And you can look up, this is also another paper that is similar concept where they, examined some patients, they, empirically got the cutoffs and they reported this algorithm. And that's essentially this algorithm, which is the Verify algorithm that's based really on the presence, your starting point is this presence of R wave in AVR. So that's always good place to look for. So to summarize, right, you are faced with a wide complex tachycardia. You can have your starting point as, dividing it to regular and irregular, with irregular really having limited possibilities of you're either dealing with VFib, polymorphic VT, or you have atrial fibrillation that in some person who already had a known wide complex, that is, bundle branch block, or you have someone who had atrial fibrillation and has accessory pathway, and then the person is just conducting nonstop through the accessory pathway. And then what the other side of that, kind of thinking is when you're faced with a regular wide complex tachycardia, then you have to, acutely manage in a simple manner, meaning, I have a wide complex, 85% based on literature, it's going to be VT. Let me stabilize the patient. But then once you get your 12-lead EKG, then you go through set of criteria and set of features of the QRS that can point you to a diagnosis. And that's important because the ramification of that diagnosis are going to be dramatic. Because if someone really had VT, we're talking about a, device, ischemic workup, etc. Versus if someone just had an SVT, we're talking maybe like a rate control and, some ablation or some very much more benign type of therapy. So now we can go through some examples and practice. So who wants to start? And I can guide you. We can go over these things. I will tell you, look for this, look for that, and then we can go together.
Look, I can start, but I'm gonna be a little lost.
Okay? Sure. Go for it.
Okay, so we have a wide complex tachycardia that's.
So I'll give you a cheat sheet. You have this,
irregular.
right? So
Yeah.
is it regular or irregular?
It's irregular.
Okay, so now look here. What are your possibilities? So you have VFib, right? You have polymorphic VT. You have I need to ask you, do you understand what is pre-excited AF?
No.
So pre-excitation means someone has accessory pathway, right? So if you start your depolarization from the atria and you're blocked in your AV node, the only way you can go is through the accessory pathway. And that's how you have delta wave, right?
Okay.
So if someone has AFib and for some reason their AV node is blocked and all of the impulses are conducted through the accessory pathway, that's the pre-excited AF or AFib. Okay. All right. So now, what else you're seeing?
So this is irregular, considered irregular, right?
Yeah. So you have irregular, right?
Okay. So I mean, it draws to my attention these narrow complex beats, the one that's a little bit before the middle of AKG, and then the two ones at the end.
Yeah. Okay. So I'll help you out with this one. So this is really going to be as you move, and I know since you want to go to cardiology, so it's going to be like more of a pattern recognition EKG. It's a very classic, and it's rare. So this is the pre-excited AFib. So what's happening here is this person has accessory pathway and has atrial fibrillation. And then you see how heart rate is extremely rapid. This is highly unusual to have such a rapid heart rate. So remember, you could have polymorphic VT, you can have AFib with a pre-existing bundle branch, and you can have this pre-excited. So for polymorphic VT to have, again, this somewhat narrowish QRSs is unusual. And then the fast rate itself, it's really characteristic for someone who has accessory pathway because that tissue itself, it's able to conduct that fast. So this is your classic pre-excited AFib. And then you see here that because and as you pointed out, the narrow beats just tell you that this person does not have a pre-existing bundle branch block. So again, it's a little bit tricky because you have to see 5 to 10 EKGs like this, and then next time you'll always recognize when you have a very, very fast irregular rhythm that kind of has wide complex with some initial slurring that is really looks like a delta wave. That's your pre-excited atrial fibrillation. So for this condition, again, it's rare. Like, usually maybe in a year you would see, 1 or 2 patients at least in our hospital. But the main thing to know here is that you should not give AV nodal blockers, because then you will block the AV node even more, and you will favor the conduction through accessory pathway, and you will worsen this condition, and then you can degenerate to VFib and cardiac arrest. So the way to go is, if you have, if hemodynamic stability is present, the drug of choice is procainamide, because it selectively acts on the accessory pathway and slows the conduction. And the other thing is just synchronized cardioversion, which is you will rarely be wrong with that. All right, so
just one question. So in
yeah.
that EKG,
Yeah.
are there delta waves? Like, are we supposed to see them?
Which one?
Are there delta waves on this EKG?
Correct. Because technically, for example, if you look at V2, it's you can appreciate in V3, and even in the inferior leads here, you can there's a negative delta wave, because delta wave can be both positive and negative. And in lead 1, you see this kind of initial slurring. But again, if you have not been exposed to this type of EKG, it will be confusing for you the first time. So that's absolutely, fine. But you should see the delta wave, because you have, the antegrade conduction through the accessory path.
And is there like a specific lead where you usually see delta waves better, or it just depends where the...
So the delta wave is always going to be seen the best in the moment when there is full pre-excitation through because what's happening when someone has accessory pathway, it's not a binary, I'm either going through accessory pathway or through AV node. It's kind of like a ratio. So these narrow beats that you're seeing here, like that you pointed out, are probably what's happening there. That's actually conduction through the AV node. And that's how this EKG would look like if it would be just Afib with these narrow QRS complexes. In certain situations, the AV node is fully blocked, and you have full conduction through the accessory pathway. And in those moments, the delta waves would be really most visible. The leads to analyze delta waves are mostly inferior leads, and then your V1 lead, and you can also look at the one in AVL. The other precordial leads can be variable.
Okay, thank you.
All right. Okay. What about this one?
I can go.
Mm-hmm.
So it's a white complex tachycardia, looks regular.
Yep.
So I'm gonna go through the 4 criteria that Bruguera.
Okay, let's go.
So the first, absence of RS, but it's not the case here. We do have RNS in the precordial leads, so that's not the case. Second would be beginning of R to the nadir FS more than 100 millisecond in any precordial lead, which is also not the case. Third would be looking at evidence of AV dissociation. I can't really, I don't know if in V1 we can see some P waves. In V1, if we can, those might be looking like a sinus, to be honest. I mean, sinus.
Okay.
I can't see any AV dissociation.
Okay.
And the fourth, be it any typical right bundle, atypical right bundle or left bundle in V1 and V5, V6. And I mean,
okay, so tell me then final diagnosis in the sense of, what is the atrial rhythm and what is the ventricle? Like, just whatever tachycardia, just give me.
It looks like there is sinus node atrial.
Okay, that's absolutely correct. So This is kind of also like a pathognomonic EKG where you have wide QRS complex, but you clearly have P waves present in V1 as you saw. But you see how it's helpful when you go through the algorithm and systematically look at EKG, because the reason why you noted so well the P waves is because you were looking actively for AV dissociation. So then you realize, wait a second, this is a sinus in front of every QRS, and I'm just dealing with sinus tachycardia and wide QRS that is some other etiology. So either there's a pre-existing bundle branch block or intraventricular conduction delay that is non-specific, because this is kind of like a non-specific pattern, if you see, right? But this, and then you remember that what I said, what you guys also should not forget is like electrolytes, drug toxicity, effects of antiarrhythmic. So this was just like a EKG of tricyclics toxicity, where you have a prolonged, a little bit of non-specific widening of the QRS, and the QT is very prolonged. If you look here, the QT is basically like almost ending at when the next QRS is starting. So that's a classic scenario. All right. So who's gonna do this one?
Luca, sorry, can I ask a question?
Yeah.
In the previous one in AVF, was there an RSR prime?
Yeah, I mean, that's how you would call it, as based on nomenclature. Again, I think this particular QRS complex, I would just classify as a non-specific ventricular conduction delay, because I don't have criteria, or I would say maybe incomplete right bundle branch block, but I don't have criteria for a full left or right bundle. But yeah, you would call this the morphology just based on the nomenclature of QRS. You would call it an RSR prime. Yeah, that's absolutely correct.
Okay, and sorry, just one more question. The fusion and the capture beats, does that show up because of the irregularity of like the nature of the arrhythmia? So some from the sinus get conducted, or?
So yeah, so not necessarily because of the irregularity of the arrhythmia, because what's happening, so arrhythmia can be regular, right?
Yeah.
But because the sinus node is working by its like completely unrelated, right? That's why you have AV dissociation. And during some moment in this cardiac depolarization, repolarization, if by pure luck, if it happens that sinus reached the AV node, and at that time the ventricle was repolarized and ready to be depolarized again, and somehow that signal from the sinus node that came to AV node got there faster than the next ventricular beat, that's going to produce your capture beat or fusion beat.
Okay.
That's basically the principle behind it, and that is just the evidence of AV dissociation, basically, and that's
okay.
all.
But
That's
you don't
all.
need irregularity for that. It's just chance.
You don't necessarily need the irregularity, exactly. I mean, that appearance, if that happens, that it will make your EKG look irregular, but your in order for that to happen, VT does not need to be irregular.
Okay, understood.
Yeah.
Thank you.
Okay. All right. Who's going to do this one?
I'll do this one, Luca.
All right, let's go.
So it's wide complex. It looks regular. And then it looks like there's positive concordance through like the precordial leads. And there's like in Beacon.
Yeah, so the only thing in terms of precordial concordance is that this QRS in V2 is a little bit like, I think this would be more kind of like a negative. So technically you don't have the precordials, but continue.
And so then looking at the RS interval, it looks like it's more than 100. So
Okay. Yeah.
this is
Yeah.
like T.
Right. So you already have like, you know, a bunch of things to suggest. And then if you continue further, I don't think I have not been able to identify AV dissociation here. But if you go through that morphological criteria, this is going to be a right bundle branch block like VT, right? And then you see you have a little QR, right? So that's one thing that goes with VT. And then if you go to V6, and then you have, it's really helpful to have a little like cheat sheet and practice this, and then it goes to memory. And then you have R to S is less than 1. That's another thing to support. So now you have 3 things to support VT, and you're very comfortable now with the diagnosis, and you know there's no question, right? Okay, good. So who wants to do this one? And we're gonna finish. This is the last one.
Bonus marks for whoever can finish out with the last one.
Yeah. Whoever can, you know, if you finish with this, you're gonna end the torture.
I can go if I'm allowed.
Yeah, yeah. Go.
So again, we'll go through the criteria, but I can't help but notice the V1, the R prime with the left ear higher than the right ear going.
Yeah, so R large R S you know, R prime, right? So that's one. Okay, that's one of the things, but never. So this is like it's very like tough to resist to jump to something like this, right? But I have picked the EKGs that are going to be straightforward. But if you jump to conclusion like this, you might make a mistake, because there are instances where you will be fooled. So that's why you should always go systematically.
Okay, so we'll start with the systematically. The first criteria doesn't, because we do have RS complexes in the precordial leads. The second one, looking at R to S to the nadir of S, looks like more than 100, if I'm not.
Yeah. Exactly. Especially V2. You have you know, clear. Yeah.
And I'm looking for AV dissociation. Probably we can see it in lead 2 in the like rhythm strip down.
Yeah, there you see here.
And different PR intervals.
Here. So this is, you know, AV, you have AV dissociation, you have RS more than 100, you have the morphological criteria, and now you're quite confident this is diagnosed with VT. And
is this the Josephson sign in V2, the notching near S, or that's not in V2 usually?
So yeah, exactly. So in V1 or V2, but that's usually applied to when you have a left bundle morphology, like left bundle branch like. So that will be the Josephson sign when you have notching in the downslope of the V2. But yeah, if this was if this V1 had a predominantly negative QRS, then you could say for V2 that this was a Josephson sign.
I see. Okay.
So the notchings on the other precordials are not; those are not the Josephson.
They are non-specific, or the notchings are usually always fragmentation and notching are a sign of a diseased ventricle, but in this particular pattern, they're not specific for any type of condition. But you have certain signs of notching on an EKG that are, you know, in a particular lead, in a particular situation, that can give you some information. All right, so I think we can conclude the session today.
Thank you so much, Luca, for that talk. We can leave it there for today, but thank you for this one and for the last one as well. These have been great.
All right, excellent. Well, thank you guys, and see you at some point soon. All right.